in 100,000.
Okay, why it is not voiding cystourethrogram? Okay, option E. A voiding cystourethrogram is performed after a first febrile UTI if patient has abnormal renal ultrasound, high fever with unusual pathogens, not E. coli, or signs of CKD. Renal ultrasound should be the first performed in patients to rule out the renal abscess. So this patient has urinary tract infection. This patient has urinary tract infection age this patient has urinary tract infection which occurs most commonly in young girls due to short urethra and close proximity to the urethral opening to the anus. E. coli is the most common pathogen. Presentation can include fever, dysuria, urgency, frequency. Urine culture is diagnostic. An empiric antibiotic, third generation cephalosporin in children, and are initiated while awaiting results. Symptoms generally improve by 48 hours. Symptoms generally improve 48 hours of appropriate antibiotic therapy. The patient with UTI The patient with UTI has persistent fever, costovertebral ankle tenderness, despite oral antibiotic therapy. These findings are mm, these findings are concerning for renal infection, either pyelonephritis or renal abscess. The next step in the management to broaden antibiotics to cover a resistance organism and to obtain renal and bladder ultrasound and an obtained renal and bladder ultrasound. An ultrasound evaluates kidney involvement as well as anatomical abnormalities that may predispose the patient to UTI hydronephrosis, suggestive of vesicoureteral reflux. Okay, yes. In management, antibiotics like cephalosporin group of antibiotics, first febrile UTI, first if there is first febrile UTI, if it is age less than 2, renal and bladder ultrasound, age less than 2 renal and bladder ultrasound, followed by voiding cystourethrogram if abnormal. If age more than two or more than two, observation alone, and recurrent febrile UTIs, renal bladder ultrasound, and voiding cystourethrum. Is it recurrent? Where it is written? The patient has UTI with the UTI organism actually, like the E. coli common organism of UTI. So they haven't said any sort of recurrence. Is there anything written about recurrence? So renal and bladder. Yes, I got that. So this should be the flow chart, like the renal and bladder ultrasound followed by VCUG. Yes, is like H2. Yes, observation alone. Yes, that's I'm thinking. Why is not observation? They can make any question in any. Uh, Better. Yes, yes. Okay. So this the clue in this question is here, like the lower abdomen is tender and palpation exacerbate the agitation. Okay, so this elderly male patient with agitation tachycardia, lower abdominal tenderness 2 days following surgical repair. 2 days following a surgical repair of hip fracture, has acute urinary retention. The major risk factor for development of acute urinary retention include acute urinary retention rarely occurs in women, advanced age, history of BPH, history of neurologic disease, and surgery. It is likely it is likely that this patient has recently taken medication, anesthetic, opioids, anticholinergic that are common precipitant of acute urinary retention. In a patient with suspected acute urinary retention who is unable to avoid, the diagnosis is confirmed by bladder ultrasound demonstrating more than 300 ml of urine. Treatment with insertion of Foley's catheter and urinary lysis should be collected to rule out urinary tract infection, a potential cause of AVR. Obesity, abdominal ascites, tissue edema may render bladder ultrasound inaccurate. In such case, Foley's catheter insertion can be both diagnostic and therapeutic. Extreme. Yes. If you are, she reports extreme weakness of the lower extremity. Normal saline. He has given potassium, even if deep tendon reflex are absent. Mm, mm. Kidney phos- It is hypokalemic, hypochloremic. Uh, and patient is a chronic alcohol use disorder. So, the very high yield point in here on physical examination, patient is cachectic. So he is unable to feed. So he is unable to take food. And now we are giving tons of things. Now what will happen? Yes, yes, you are on the right track. Yes. Okay. This patient with chronic alcohol use disorder developed developed diffuse weakness, chronic alcohol use disorder developed diffuse weakness and hyporeflexia after receiving dextrose containing IV fluid. After receiving dextrose containing IV fluid, suggesting the development of refeeding syndrome. Refeeding syndrome occurs in the setting of hypophosphatemia due to malnutrition, alcohol use, and anorexia. Patients with alcohol use disorder are particularly elevated risk of alcohol-induced chronic diarrhea, reduces intestinal phosphate absorption, and gastritis. The reintroduction of the carbohydrate 5% dextrose containing IV fluid in, in patients with chronic hypophosphatemia leads to increased insulin secretion. This stimulates the intracellular shift of electrolyte, phosphate, potassium, magnesium, and increases phosphate utilization during glycolysis, formation of ATP 2,3-diphosphoglycerate, resulting in phosphate depletion and failure of cellular energy metabolism. Manifestations include muscle weakness, hyporeflexia, rhabdomyolysis, hemolysis, arrhythmia, congestive heart failure. In addition to hypophosphatemia, hypokalemia, hypomagnesemia, and elevated liver function studies are typical. The diagnosis is confirmed by low serum phosphorus level. Management includes close lab monitoring of electrolytes with aggressive electrolyte repletion. Okay. Yes. So in refeeding syndrome, there is starvation catabolic state. So decrease insulin, increase glucagon and cortisol, decrease ketone bodies used in muscle, increase ketone bodies in brain, decrease the ketone body in muscle, increase ketone body in the brain. There is increased glycogenolysis, lipolysis, and protein catabolism. Glycogenolysis, lipolysis, and protein catabolism. Depletion of fat, protein, vitamin, minerals, and intracellular electrolyte. Start refeeding syndrome, state. Anabolic state which will increase insulin, increase glycogen synthesis, increase protein synthesis, increase intracellular uptake of phosphorus, potassium, and magnesium and thiamine, decrease serum phosphorus, potassium, magnesium, decrease serum thiamine, and increase sodium and water retention. There may be arrhythmia, congestive heart failure, pulmonary edema, peripheral edema. There may be seizure and peripheral Wernicke encephalopathy. Okay.
65 men evaluated the section chest. Is it
He is doing angiography, isn't it? Yes, we contrast, we are giving fluid. What will metformin do? Metformin causing acidosis. Like metformin can cause metabolic acidosis, isn't it? So in contrast, we need the contrast thing to go out from our system, like kidneys. So we need fluid. Okay, okay. Contrast associated AKI. Contrast associated AKI. This patient with exertional chest pain. This patient with exertional chest pain is scheduled for diagnostic coronary angiography, which requires the use of intra-arterial contrast for coronary artery visualization. Intra-arterial contrast administration can cause contrast-associated AKI that is characterized by rise in serum creatinine within 24 to 48 hours, followed by a gradual return to baseline. Risk factors include CKD, particularly diabetic nephropathy, high contrast load, use of NSAIDs and hypovolemia. So contrast associated AKI is likely caused by a combination of direct cytotoxicity causing mild acute tubular necrosis and contrast-induced renal vasoconstriction leading to renal hypoxia and cellular injury. The risk of contrast-associated AKI is reduced with periprocedural volume expansion with intravenous 0.9% saline in patients with chronic kidney disease who do not have clinical evidence of volume overload, jugular venous distension. In addition, holding NSAIDs as well as using the smallest possible volume of contrast are further measures that reduce the risk of contrast associated AKI. Okay, yes. Highest risk highest risk with arterial iodinated contrast, coronary angiogram. Creatinine elevation 24 to 48 hours after contrast exposure, gradually return to baseline within 3 to 7 days. Clinical diagnosis based on timing and trajectory above. Biopsy rarely need. Risk factor is pre-existing chronic kidney disease, especially diabetic nephropathy, decreased kidney perfusion in sites, hypovolemia, venous congestion, and mm, high contrast load. Pathophysiology is prerenal vasoconstriction and direct tubular hydroxycity. Prerenal state FeNA less than 1 with concurrent necrosis, muddy brown casts. Prevention optimize kidney perfusion, intravenous saline, avoidance of NSAIDs, minimize contrast load. Okay.
Do they all avoid we are forgetting about that?
Okay. Normal urine output in unit is defined as more than 1 watt per day of life. One or more than one watt per day of life. The infant has only one single wet diaper the first 24 hours of life, therefore, as oliguria from neonatal acute kidney injury. All neonates with oliguria require further evaluation with the following history and physical examination to evaluate for possible risk factor: nephrotoxin, family history, renal anomaly, and volume status, volume overload versus hypovolemia. Renal and bladder ultrasound, which documents the number, shape, size of the kidney and detects vascular abnormality of the congenital anomalies, which are particularly concerning in patients with no prenatal care. An intravenous fluid bolus is often used when hypovolemia. An intravenous fluid bolus is often used when hypovolemia, excessive weight loss, dry lips from prenatal disease is suspended. Causes of neonatal oliguria, however, establishing normal renal anatomy is required first because in neonates with obstructive uropathy or renal dysplasia, fluid bolus could be a fluid bolus could lead to volume overload since the kidneys are unable to remove the excess fluid. In addition, the patient has appropriate weight loss, less than 10% weight changes at day 2 is formula feeding well, and a formula feeding well suggests a normal volume status. Okay, what happened? So we need to find out the is there any anomaly renal and bladder doing renal and bladder ultrasound. Why is not urinating? Yes. 2 days, yes, once. First 28 days. If it is 28 days, then 28 times. I I I think that uh it should be like for a week. If it is if it is neonate, like if neo look at the definition of the neonate from birth to the 28 days. So it 28 days, is it possible to peeing 28 times? Yes. Okay. Heart failure. Wait, heart failure is pre-renal leakia, isn't it?
Heart failure is busy.
Yes. He has he has clear heart failure signs like S3, like JVP is raised, and look at the BUN creatinine ratio more than 20 or more than 15. So it's pre-renal AKI. 20 something, more than 20. So it's pre-renal AKI. Think about the pre-renal causes. Glomerular hyperfiltration is renal causes. Renal artery stenosis. Wait, look at the age first. Maybe, but in renal artery stenosis, there may not be heart failure. Low oncotic for liver, it's not heart. Low oncotic or osmotic pressure, it's for like cirrhosis. It is also pre-renal AKI, but it is not related to heart. Think about something related to heart. Okay, first you need to find out it is pre-renal, then you need to think about the causes. Cause regarding the features. In here there is clear cause of heart, so you need to find something related to heart. Okay, it's cardiorenal syndrome. Another complex syndrome. Okay, this patient with AKI with elevated blood pressure, this patient with AKI with elevated blood, AKI with elevated BUN creatine 20:1, unremarkable urinalysis suggesting a pre-renal cause. Also, although pre-renal AKI, although pre-renal AKI results from total body volume depletion, it it can also occur in volume overload status that involve reduced effective arterial blood volume. This patient has volume overload due to acute heart failure exacerbation, and the AKI most likely due to cardiorenal syndrome. Cardiorenal syndrome involves mutually detrimental interaction between the heart and the kidney. So, detrimental interaction between the heart and the kidney. Left ventricular failure with reduced cardiac output. Left ventricular failure with reduced cardiac output that leads to decreased renal perfusion. Followed by activation of the renin-angiotensin-aldosterone system. The increase in RAS activity causes vasoconstriction and volume retention, which increase the load on the left ventricle and further reduces renal perfusion. Elevated central venous pressure is likely the major driver of AKI in cardiorenal syndrome. The elevated central venous pressure leads to elevated renal venous pressure and congestion. These reduce the glomerular capillary. This reduces the glomerular capillary filtration gradient, possibly due to interstitial edema from venous congestion, increasing Bowman's capsule hydrostatic pressure. The result is a reduction of the glomerular filtration rate, decreased renal perfusion due to reduced cardiac output, also has a role in reduced GFR. Diuretics are usually most effective therapy for AKI due to cardiorenal syndrome. The resulting reduction in renal venous pressure restores the glomerular capillary filtration gradient and improves GFR. Okay, okay, cardiorenal syndrome. Cardiorenal syndrome, left ventricle and right ventricular failure. In left ventricular and right ventricular failure, there is increased central venous pressure and renal, increased central venous and renal venous pressure. Increased central venous and renal venous pressure, which will decrease glomerular capillary filtration gradient, which will decrease the GFR. Decreased GFR will increase RAS. RAS will be activated, so sodium and water will be reabsorbed. More and more sodium will be water and reabsorption, and there is vasoconstriction, which will cause left and right ventricular failure. And left and right ventricular failure will decrease cardiac output, decrease renal artery perfusion, Again, it will decrease GFR RAS activation. Okay. So venous congestion and reduce blood flow, two mechanism. Yes. Glomerular hyperfiltration is the early stages of diabetic nephropathy and is recognized by temporary increase in GFR, low blood oncotic pressure occurs in nephrotic syndrome, but it is not typical of heart failure. Nephrotic syndrome involves total body volume overload with intravascular volume depletion. Prerenal AKI can occur due to reduced effective arterial blood volume. Okay. Neph- Nephrotic syndrome involves total volume overload with intravascular volume depletion. Okay. What happens in nephrotic syndrome? You think about a boy with nephrotic syndrome. His tummy is swollen, his face is swollen, his foot is swollen, everything is swollen. But in the vessel, there is intravascular volume is depleted, like fluid leak out into the circulation, but as there is no protein, as there is no low albumin, what happens in the nephrotic syndrome? There is low albumin. So as there is low albumin, so low albumin causing the protein, low albumin causing to water to come out into the circulation. So total body volume is increased, but in the vessel intravascular volume is depleted. Like if you think about the ECF ICF, so that volume is depleted, but total body volume is uh, overloaded. That they are trying to mean. And prerenal AKI is happening due to reduced effective arterial blood volume, as there is uh, if as there is reduced effective arterial blood volume, so that is causing the prerenal leakage. What will happen if there is reduced effective arterial blood volume? It will decrease the renal perfusion. As it will decrease the renal perfusion, then it will cause the prerenal leakage. No, no. Yes, patients with bilateral renal artery stenosis have mm, a maintained GFR thanks to angiotensin 2 mediated effective arteriolar constriction. In these patients, starting AC inhibitor and ARB removes angiotensin 2 activity and can cause AKI. So that was your previous day's question. Okay, this patient has been on lisinopril and had normal renal kidney function just 3 weeks ago, making bilateral renal artery stenosis highly unlikely. So, patient with bilateral renal artery stenosis typically have maintained GFR thanks to angiotensin 2 mediated effective arteriolar constriction. In this patient, starting with AC inhibitor or ARB, removes the angiotensin 2 activity and can cause AKI. That is your answer. You are talking about why bilateral renal arteries, why ACE inhibitor causes AKI in bilateral. Yes, yes. So that is your answer. Okay. Today we are performing renal and bladder ultrasound a lot. Okay. So I think that we do not need this explanation. Do you? Okay. This is the same monotonous explanation. Okay. These young, okay, this young, previously healthy patient has developed sudden onset generalized edema, lower extremity, and periorbital edema ascites with weight gain. Hypoalbuminemia suggests Hypoalbuminemia suggests that the cause is nephrotic syndrome, which involves increased permeability of the glomerular capillary, increased permeability of the glomerular capillary, leading to urinary albumin loss. Hypoalbuminemia leads to decreased plasma uh, oncotic pressure, thereby causing fluid to shift from intravascular space into the interstitial space. To compensate, the decreased plasma oncotic pressure seems to stimulate increased hepatic synthesis of protein, including albumin. In addition, there is increased hepatic synthesis of lipoprotein as well as decreased LDL clearance. decrease LDL clearance, decrease LDL clearance, which cause due to increased synthesis of proprotein convertase subtilin casein type 9, which causes LDL receptor degradation. These two factors combined with decreased endothelial lipoprotein lipase activity results in hyperlipidemia, thereby increasing the risk for accelerated atherosclerosis. Nephrotic syndrome also leads to following complication: thrombotic events and bacterial infection. Thrombotic events: DVT, pulmonary embolism, renal vein thrombosis due to urinary loss of natural anticoagulant antithrombin 3 protein C and S. Bacterial infection, particularly from encapsulated organisms, Streptococcus pneumoniae due to urinary loss of immunoglobulin, humoral immunity. Additional findings may include vitamin D deficiency, urinary loss of vitamin D binding protein, and anemia, urinary loss of transferrin and erythropoietin. Okay,
When you see chemo, previously has been one of the patient would recognize
it is sarcoidosis. What does she has?
that we know. But
You search calcitriol is 125 dihydroxycholecalciferol, like active calcium. Yes. What is the skin finding? Is yes, and the face one. Okay, it's papular sarcoidosis written in the explanation. Okay, uh, this young patient This young patient with non-productive cough, this young patient with non-productive cough, lymphadenopathy, rash, symptoms of hypercalcemia, constipation, symptoms of hypercalcemia, constipation, fatigue, likely has sarcoidosis, a multisystem granulomatous disorder, skin involvement up to 25% cases as seen in this patient with erythema nodosum violaceous indurated nodules on the shins, papular sarcoidosis, pap- papular sarcoidosis, multiple scattered papules on multiple scattered papular lesions on the face, impairment of calcium homeostasis in sarcoidosis are primarily driven by 1-alpha hydroxylase activity, which normally converts calcidiol 25 hydroxy vitamin D, calcidiol diol into calcitriol 125 dihydroxy vitamin D into 125 dihydroxy vitamin D only in the kidneys. In sarcoidosis, abnormal abnormal extrarenal calcitriol elevation occurs in activated macrophage in lungs and lymph node, causing a cascade of effects. Serum calcitriol increases, which stimulate intestinal calcium absorption, causing hypercalcemia. Parathyroid hormone decrease the negative feedback by hypercalcemia, increasing calcitriol. Renal calcium reabsorption decreases due to low PTH. Serum calcium is big. Renal excretion increases. I don't get these 3 points. Can you explain me? Like this calcitriol. Yes. And why PTH is low? Yes. Give negative feedback. Urinary calcium. So in here the main pathophysiology is 1-alpha hydroxylase activity. Mm, The other options. Yes. Okay. Hypercalcemia in sarcoidosis. Hypercalcemia in sarcoidosis result from abnormal calcitriol, not PTH production. Therefore, it is not PTH dependent. In contrast, PTH dependent hypercalcemia involve failed negative feedback such as PTH inappropriately high, unsuppressed, despite high calcitriol and hypercalcemia. Primary hyperparathyroidism is the most common cause. Urinary calcium levels in hyperparathyroidism can be increased or normal depending on the severity of the hypercalcemia. I don't get this part also. This para. Okay. Yeah. Yes. This regulation of calcium metabolism. Regulation of calcium metabolism. Parathyroid hormone. It will increase bone resorption. It will increase renal reabsorption of calcium. Increase renal reabsorption of calcium and decrease reabsorption of phosphate and increase conversion of 25 hydroxyvitamin D to 125 hydroxyvitamin D. Vitamin D will increase in the cell absorption of calcium and phosphate, increase renal reabsorption of calcium and phosphate, decrease parathyroid hormone secretion, and increase mineralization of the bone, calcitonin, decrease bone resorption, and decrease renal calcium reabsorption. Okay. Decrease reabsorption. Yes, that's the thing. On that box, they actually uh, write wrong. Maybe there is an arrow like decrease reabsorption of phosphate. Yes, yes, okay. in addition to hematuria, this patient has dysuria and pyuria. Hematuria, dysuria, pyuria, which are consistent with urinary tract infection. UTI is one of the more common cause of transient hematuria due to leaky blood vessel associated with urinary tract inflammation. Additional signs and symptoms of UTI may not be always present, include fever, urinary urgency, frequency, and the presence of nitrate and leukocytosterase in urine. The next step of um, a patient who has characteristic UTI symptom or urinary lysis, finding begin empiric antibiotic therapy. A urine culture should be obtained and bacterial growth, most commonly E. coli, confirmed the diagnosis. Notably, although sexually active adolescent with dysuria and pyuria should undergo screening for gonorrhea and chlamydia, gross hematuria is atypical. Patient should be repeated for The patient should be repeated a few weeks after completion of antibiotic for patient initially presenting with blood in the urine to ensure resolution of hematuria after UTI treatment. A UTI without initial hematuria can be typically followed clinical resolution of symptoms. Okay. CT scan of the abdomen is indicated to identify the source of the bleeding with hematuria and a history of trauma, which is not seen here. Cystoscopy Cystoscopy may be used to evaluate for bladder cancer, which is rare in children and adolescent and patients with painless hematuria. And kidney biopsy may be diagnosed for glomerulonephritis, IgA nephropathy in patients with persistent hematuria, plus proteinuria, hypertension, elevated creatinine. This patient characteristics UTI and urine analysis with lack of proteinuria make invasive testing unnecessary. Renal ultrasound is preferred the imaging study in children to assess for nephrolithiasis, which can present with hematuria and dysuria, but also typically cause flank or abdominal pain. Renal ultrasound may be indicated to assess for complication of pyelonephritis in a patient with UTI that does not respond to antibiotic treatment. Empiric antibiotic priority in this patient. Okay, okay, yes. Evaluation of hematuria in children. If hematuria means 3 or more than 3 RBC, is it glomerular or non-glomerular? If it is glomerular, then CCC, CBC, creatinine, and complement level. For glomerular hematuria, triple C, and non-glomerular hematuria in non-glomerular asymptomatic patient, renal ultrasonography, urine culture, urine calcium creatinine ratio. Non-glomerular symptomatic, non-glomerular symptomatic. If it is trauma, then CT scan of the abdomen. If it is UTI, then urine culture and antibiotic. If it is perineal or meatal irritation, reassurance. If it is kidney stone, then renal ultrasonography. I was on the track. Hypokalemic hypochloremic metabolic alkalosis due to vomiting, but urine sodium actually the problem. Okay. This patient has severe this patient has severe vomiting, possibly due to untreated. This patient has severe vomiting, possibly due to untreated peptic ulcer. Now has evidence of volume depletion, dry mucous membrane, tachycardia, vomiting causes a significant loss of vomiting causes a significant loss of gastric pH. Vomiting causes a significant loss of gastric hydrogen from the body. It causes low it causes loss of water and salt with relatively more loss of chloride than sodium with relatively more loss of chloride than sodium due to high gastric quantity of hydrochloric acid. These also triggers characteristics electrolyte abnormality, resulting in hypokalemic hypochloremic metabolic alkalosis. The loss of hydrogen reduces the carbonic acid buffer in the body, resulting in increase in relative quantity of bicarbonate. Metabolic alkalosis is initiated with increased serum bicarbonate. Metabolic alkalosis is initiated with increased serum bicarbonate. Increasing serum bicarbonate. Okay. Volume loss decreases renal perfusion, activates RAS. The secondary hyperaldosteronism stimulates sodium reabsorption in the distal tubule at an expense of increased potassium and hydrogen creation. This leads to hypokalemia and worsens metabolic alkalosis. The loss of chloride from the stomach and kidney leads to profound total body chloride depletion, that is hypochloremia. Because adequate chloride delivery to the distal renal tubule is required for appropriate excretion of bicarbonate via pendrin exchanger, the chloride Depletion causes impaired the chloride depletion causes impaired bicarbonate excretion and perpetuates metabolic alkalosis. Urine sodium and urine chloride is low due to total body depletion and aldosterone mediated renal tubular reabsorption. Urine sodium and urine chloride may be low due to total body depletion and aldosterone mediated renal tubular reabsorption. Clinically low urine chloride is an important indicator of the etiology and appropriate metabolic alkalosis. It is expected findings in etiology metabolic alkalosis that are permits driven by chloride depletion, severe vomiting, diarrhea, and indicates the repletion of volume and chloride with normal saline which shut off the mechanism perpetuating alkalosis and allow serum electrolyte to normalize saline response. Okay, these two things is low because total body depletion and aldosterone mediated renal tubular reabsorption. Okay, this patient has nephrotic syndrome from membranous nephropathy. Membranous nephropathy characterized by kidney biopsy. Characterized by kidney biopsy showing diffuse glomerular basement membrane thickening with granular IgG and C3 deposit. Membranous nephropathy is often primary autoimmunity to normal podocyte antigen, which typically results in positive serology, phospholipase A2 receptor or autoantibodies, or tissue stain. Phospholipase A2 receptor antigen results. Negative test results from primary membranous nephropathy, as in this patient with negative tissue stain, warrant evaluation of secondary cause of membranous nephropathy. These include membranous malignancy, solid tumor, autoimmune disease, infection, and medication. Solid tumors, lung, colon, breast, autoimmune disease, SLE. Most common infection is hepatitis B, C, HIV, syphilis, and medication, NSAID, drugs, penicillin. This patient takes no medication and has no evidence of culprit infection. Negative hepatitis B and HIV, has no antinuclear antibody with no features of SLE. Therefore, membranous nephropathy secondary to malignancy must be considered. Although malignancy is often clinically apparent before the onset of membranous nephropathy can sometimes be the presenting feature of occult malignancy. Membranous nephropathy can sometimes be the occult feature of the malignancy. Therefore, patients should undergo age-appropriate cancer screening, colonoscopy, mammography. More extensive screening should be guided by the risk factor. The patient should undergo CT scan of the chest, giving his smoking history and age. Okay, yes. Mm, okay. Membranous nephropathy. Membranous nephropathy is immune-mediated podocyte injury. Primary phospholipase A2 receptor um, autoantibodies. Secondary infection, hepatitis B, malignancy, autoimmune, SLE, medication, NSAID. Clinical syndrome is nephrotic syndrome, increased thromboembolic risk. Nephrotic syndrome, increased thromboembolic risk. Diagnosis: microscopy, diffuse GBM thickening, spikes on light microscopy, granular IgG and C3 on immunofluorescence, subepithelial deposits and podocyte effacement on electron microscopy. Lab testing: primary phospholipase A2 receptor studies, secondary ANA virus cancer screening. Treatment is all patient supportive care, RAS blockade, loop diuretics, primary monitoring, low risk, spontaneous remission, immunofluorescence, higher risk, secondary therapy for underlying cause. Okay, okay. This nebulized albuterol can cause hypokalemia. This patient has COPD, isn't it? So albuterol beta agonist can uh, cause more and more potassium into the cell, thus causing hypokalemia. Okay. low serum low serum potassium may result from increased potassium entry into the cells, renal potassium wasting, or GI fluid loss. This patient with an acute exacerbation of COPD is treated with an uh, uh, inhaled beta 2 adrenergic agent albuterol. Exogenous and endogenous epinephrine beta-adrenergic agonist can cause potassium shift into the intercellular space the by stimulating the sodium potassium ATPase pump and the sodium potassium to chloride cotransporter. Adrenergic agents also stimulate the release of insulin, which further promotes the intercellular potassium shift, causing hypokalemia. Okay. It's nephritic syndrome, isn't it? And nephritic due to drug. Okay. These patients, the clinical presentation is typically acute allergic interstitial nephritis AI and acute renal failure, fever, rash, and a recent history of PABA, parabenzoic acid. Analog antibiotic sulfonamide injection, white blood cell casts on analysis patients may have arthalgia and eosinophiliria. Symptoms usually appear 5 days to several weeks after use of an offending agent. Drugs can cause majority of the causes. Example include antibiotics, penicillin, cephalosporin, trimethoprim, rifampin, NSAID, diuretics less commonly and may be caused by infection agent Legionella, Mycobacterium, tuberculosis, streptococcus. Okay, next. Okay, AIN, acute institutional nephritis drugs, penicillin, trimethoprim, sulfamethoxazole, cephalosporin, NSAIDs. Clinical feature maculopapular rash, fever, new drug exposure, with or without arthalgia, lab finding, acute kidney injury, pyuria, hematuria, WBC, CAS, eosinophilia, urinary eosinophil is I. Urinary eosinophil. Is it given urinary eosinophil in here? No. Renal biopsy, inflammatory infiltrate or edema. Management is discontinue offending agent with or without systemic glucocorticoid. Okay, next. The final one. What is your thought? Why you are wait, just calm down. Look at the question again. So in here there is plenty of thing. Most important is there is hypocalcemia, there is hyperkalemia, so some sort of electrolyte imbalance, and the patient is on opioid. So opioid is causing some sort of kidney problem, isn't it? L- uh, so so think about like uh, any kind of AKI. Yes, neck fash. Why neck fash will happen? So this patient, it is rhabdomyolysis due to opioid and alcohol. So this patient who has a history of substance use, yes, this patient who has a history of substance use, opioid alcohol was opioid alcohol was found down by a friend as lab finding consistent with rhabdomyolysis is at greatest risk of developing AKI. Rhabdomyolysis results from large scale skeletal muscle necrosis via mechanism that include crash injury, ischemic injury, overexertion, and direct myocyte injury. Opioids and other CNS depressant, ethanol, benzodiazepine can cause rhabdomyolysis by inducing impaired consciousness with electrolyte immobilization and ischemic compression of dependent areas of skeletal muscle, mottled skin over back, buttocks, uh, and posterior thighs. AKI in rhabdomyolysis predominantly results from decreased renal perfusion due to intravascular volume depletion from shifting of fluid into the damaged muscle tissue and direct renal tubular toxicity of heme pigments which are contained in myoglobin proteins released from lysed muscle cell. And increased in serum creatinine is often delayed from presentation but can be profound over ensuing days. Other lab abnormalities indicating of rhabdomyolysis, all of which are seen in this patient, include hyperkalemia, hyperphosphatemia, which results from the release of this electrolyte from lysed muscle cell into the bloodstream, hypocalcemia, which is often present due to deposition of calcium into the damaged muscle tissue. Moderate transaminase levels, which characteristically show greater elevation in AST than ALT due to relatively higher levels of AST in skeletal muscle. Okay, okay, okay. Bye bye.